Hi, welcome to JAMA Network Open Live. I'm Seth Truger, Digital Media Editor, JAMA Network Open.
And I'm Angel Desai, JAMA Fishbein Fellow.
Of course, if you're following along, send us your questions or comments on Twitter at JAMA Network Open, or you can comment under the video frames in the comment box on YouTube or Facebook Live. So for our first paper today, we have something very topical: the effect of high versus low doses of chloroquine diphosphate as adjunctive therapy for patients hospitalized with severe acute respiratory syndrome coronavirus 2 infection, a randomized clinical trial. And the authors are from Brazil, so unfortunately we couldn't bring them. But even better, we have one of the associate editors from JAMA Network Open who co-wrote the accompanying invited commentary, Steve Bradley. Welcome, Dr. Bradley.
It's good to be here. Thanks for having me.
Great. So, Steve, give us a little bit of background on who you are and what's going on with the paper here.
Yeah, sure. So my name's Steve Bradley. I'm a general non-invasive cardiologist at the Minneapolis Heart Institute and Minneapolis Heart Institute Foundation. I'm trained as an epidemiologist and health services researcher and worked for a number of years in the VA healthcare setting, working in quality improvement for VA cath labs. And then have joined Minneapolis Heart Institute recently, looking at determinants of value and working to achieve best outcomes and care for our patients. And I've been with JAMA Network Open since the inception of the journal as an associate editor, and one of the highlights of my career and what I get to do on a day-by-day basis.
Yeah. Well, great. We're really glad you could join us. So tell us about the study.
Yeah, so a very important study and important for us to share this information. So a randomized, non-placebo-controlled, double-arm trial comparing 2 doses of chloroquine in patients with COVID-19. I'll say I am post-call, so the brain's working at about 75%. So when I stumble over that, it's fatigue, not anxiety. At any rate, so this was a comparison of these 2 arms of these doses. They chose the doses based on prior in vitro studies of chloroquine for patients for viral studies showing that it reduced viral effectiveness or potentially antiviral effects. So this high-dose arm versus a low-dose arm, the high dose being 600 milligrams twice a day for 10 days, and intended to enroll 440 patients. They thought they would lose some patients, and then looking for about a 50% effect size in mortality. And as part of this trial, there were pre-specified analysis points to make sure that they understood if there was futility in the trial or excess mortality. And as part of that, they're constantly providing feedback to their data safety monitoring board about mortality events. And after a very small number of patients were enrolled, 81 patients, there was a high signal of mortality in that high-dose drug that led to them stopping the high-dose arm and this publication that was published now. So I think the trial started in late March, if I remember correctly, around March 26th, and then this paper was submitted to us shortly thereafter. So this paper was published almost within a month of the trial being initiated and speaks to the speed at which this evidence is coming forth.
Yeah, I mean, it's just been a crazy new world where everything is so different now, especially when it comes to COVID things. It's, there are a lot of heartening things there about how much we've accelerated, our treatment algorithms, our approach to science and publishing, which is great. And I think figure 2 kind of shows everything you were just talking about where, as you said, they didn't have a placebo control, but they used that gray band in the mortality rates here is the kind of estimates for mortality from across other similar study populations, and then you can see both arms dip below pretty quickly within 2 weeks of study onset. So, it's always hard to know if the patients are sicker or different, but this is why we have DSMBs. So they're looking at the data and seeing if we're accidentally hurting people at the beginning of a study.
Absolutely, and there are aspects of the trial that make us still uncertain about chloroquine in general. So in this patient population, because of the other evidence, or we'll put evidence in quotation marks about chloroquine or hydroxychloroquine combined with azithromycin, 100% of the patients in this trial were concurrently on azithromycin. Both of those medications have potential to prolong the QT interval and potential cardiotoxic events or rhythm abnormalities as a result. So this doesn't answer whether or not chloroquine on its own is safe, but certainly in this dose relative to a lower dose in the setting of azithromycin, there's higher mortality.
Yeah. And I think I had seen too that many of the patients had also received oseltamivir. at some point as well, which certainly.
Yeah, you're right. Yeah, absolutely. More than 85%. So standard of practice in Brazil is essentially to use that drug at times where influenza is prevalent. And so I think they said January through April, they typically use oseltamivir for influenza. So at the time that patients are being admitted for severe acute respiratory syndrome, and it's not 100% that this is COVID relative to flu, 85, 86% of those patients were on oseltamivir as well, which has impacts on QTC interval.
Yeah. I'm going to welcome Alvin Phelps, who's joined us. And that's interesting that you mentioned that the co-infection. We saw some data early on that showed that a lot of patients did test positive for co-infections when they had in addition to COVID. But one of the other questionable is the wrong word. Interesting points of the study is only about 3/4 of the patients tested positive for COVID using PCR. But they all had what they called, clinical and epidemiological evidence of disease, which is really what we're seeing. We see a ton of patients who initially test positive or throughout the course of the disease test positive until they get, I've seen patients with like 3 PCRs negative, and then the bronch on hospital day 15 is positive or something like that. And we just know the negative predictive value is terrible, unfortunately.
Yeah, absolutely. We're seeing the same thing in our clinical practice. It all fits, but the sensitivity of the PCR test is not adequate for us to say after one test that these are truly patients who are not infected with SARS-2.
Right. Absolutely. So kind of some of the other questions I've heard are, it's always, I come from the position that you can critique even the best studies, but so these aren't necessarily questions about the study's methodology, but just as far as interpretation and external validity. Can you talk about the lack of a placebo arm in this study a little more?
Yeah. So I think that's an interesting point in general, and it speaks to the era in which we're living about concerns of acceptability of a placebo arm. So essentially, the authors write in a way that it feels that there was pressure to use this therapy, and so they needed to find a way that they could use this therapy and test its safety and effectiveness in the absence of a placebo arm. And so what they chose to do was use these 2 dose regimens and compare it to both historical controls within Brazil and other populations to see what the effect looked like in terms of mortality. And, I think we're seeing this also in clinical practice. It's this omission bias, this concept that I can't just stand here, I need to do something. Because in retrospect, we feel worse if there was something we could have done rather than if we and find out that was the wrong thing, rather than to not do something and find out that was the wrong thing. So it speaks also to the challenge of clinical equipoise, just how fragile a concept that is.
Good. Yeah, and as you say, there's such a I think innate desire to want to do something. I think we mentioned this last week where I sneezed once and I was like, oh no, should I take zinc or do something? Is there anything I can do? And I think if nothing else, again, we saw with that some of the original studies that came out, compassionate use and things like that. It certainly in the throes of pandemic, it makes sense, especially in the sickest patients, to try things, because why not? If we expect really high mortality rates anyway. I think one of the things that I take away from this study is it certainly adds to the equipoise for placebo control, given all the different noise out there.
Yeah, absolutely. And, to speak to that why not component, I think it's important to recognize that there is a why not, right? There are toxicities for these therapies. These are not without potential downstream or adverse consequences. And so we need to be very open and transparent with patients when we're doing things that lack evidence, that this isn't without potential risk.
Right. Yeah. I can't pretend to know much about dosing of chloroquine or hydroxychloroquine, but have heard, again, that these, even the low dose is a pretty high regimen of chloroquine or hydroxychloroquine equivalent. Can you speak to that at all?
Yeah, that was my sense from reading these studies as well. They compare these dosing regimens to typical dosing regimens for chronic conditions like rheumatoid arthritis or even management of malaria. And they are much higher doses than you would use in those chronic settings. The thought is that you need a higher dose to be effective in terms of its antiviral properties. And so based on that premise of a high dose needed for antiviral, a lower dose needed for these chronic inflammatory conditions or malaria, that we need to test the higher dose to see if it's going to have effect, because it's actually going to be effective. We need to know that at the higher dose relative to starting at a low dose and going from there.
I guess the other question I had was that it seemed like there were more patients in the high dose group that were also older. which may speak to the fact that, they were older and potentially sicker. And so although I guess maybe not, but in any case, they happened to be older. And so I did wonder about, whether or not those patients were at higher risk for having adverse events on their own.
Yeah, you're absolutely right. There was a higher proportion of patients who were older, had cardiovascular conditions at baseline in the high dose group. It speaks to the challenges of achieving balance at small sample sizes and even in randomized trials. They did do a multivariate analysis where they looked to see if after they controlled or adjusted for the differences in age, whether or not there was still that effect of higher mortality. It was no longer statistically significant. I think the odds ratio was something like 2.8. So the point estimate's still severely opposed to benefit for the higher dose, but does raise questions about whether or not some imbalance between the treatment arms could have played into the effect that we saw.
Right, but I will say, my double cynicism here is that sorry, I was getting some spam. My double cynicism here is that the low dose group had a higher mortality rate than we've been seeing reported in other studies too. So it's not like this was just an isolated fluke of the high dose group doing poorly.
Yeah, but I think that's a really good point. But we have to be careful about what does mortality look like in Brazil relative to Italy, relative to China. So are there really similar patient populations? Are they really similar medical management? What were the limitations in those different settings? So certainly gives pause, but is on the lower level of evidence in terms of our understanding.
Yep. Yeah, and that's I think a common question too that comes up is these were pretty sick patients who were pretty advanced in disease, hospitalized patients. They're similar to a lot of the sicker patients that I take care of. But I think there's, especially kind of in the lay public, there's a lot of hope. Would something like chloroquine or hydroxychloroquine be better for early symptoms or prevention? I don't think this study can answer that. But what do you think?
No, yeah, absolutely not. And I know that there are randomized trials ongoing right now for prophylaxis, particularly in healthcare workers. I saw some of those being ruled out through the CORNET, and this doesn't speak to that at all. You're right.
Yep. Which is, it's always the balance between internal validity and external validity, and patients with the sickest patients potentially have the most benefit, but may not be representative of other populations, and no research is perfect.
Right.
Perfect for every setting.
Right. Particularly not in this setting. Yeah.
Yeah. Another question I had for you as a cardiologist is, one of the main concerns with chloroquine is the QT prolongation, especially as you're mentioning with the Azithro and the oseltamivir, which I think I'm pronouncing a third way. So we're covering all different options.
Yeah, we've got it all.
And I'm assuming mine's wrong. Is there any signal that we can suss out of here that it was actually QT prolongation that was impacting these outcomes here?
Yeah, that's a good question. And it speaks to a number of different points. So when we think about using this medication, oftentimes we'll get a baseline EKG to assess QT baseline and say certain patient populations we're not going to use this in because the risk is too high. A baseline EKG was obtained, but there were no exclusions for baseline QTC interval. So whether or not there were some patients that typically we wouldn't give this drug to anyway, we're not sure. Second, although they looked at QTC intervals at 13 days, they didn't look immediately after initiation of this therapy. And typically when we use this in settings, we would often look to see, has there been QTC prolongation? And again, kick patients out who have prolongation because of the concerns. So those raise questions. But at the same time, when we look at the outcomes within this trial, we didn't see harbingers of QTC prolongation being the impact in terms of mortality. So you would expect to see higher rates of torsade de pointe as being the rhythm that's associated with QTC prolongation and ventricular arrhythmias. And they didn't see that. So it didn't seem that the mechanism of mortality observed in the study was related to QTC prolongation. So a lot of emphasis on that baseline risk and the risk associated with QTC prolongation, but not a signal of that being the way by which people died.
Great. Well, thanks. This has been really fascinating. I love talking about this stuff, and it's obviously so timely. Any other final thoughts? No, I really appreciate the opportunity to be here today. This was a lot of fun, and thanks for everybody for watching. Yeah, thank you so much for your work and for joining us today. Take care. Have a great rest of your day. Thanks, you too. All right, Angel, you've got another COVID paper for us.
I do, yes. This is a research letter, Epidemiological Assessment of Imported Coronavirus Disease 2019 Cases in the Most Affected City Outside of Hubei Province, Wenzhou, China. So this is by Yi and colleagues. And this was a study, it was a modeling exercise. It looked at 400, or they incorporated rather, information from 482 patients. Just a few stats about the patients here. So these were patients that were in this area, or the city of Wenzhou, which is a city of about 9 million people, and it's about 600 miles away from Wuhan, which, as we all know, is sort of the original epicenter of this pandemic. And the other sort of unique thing about this area that I gleaned from the paper was that there seems to be a lot of sort of travel back and forth, or some amount of travel back and forth between these two areas. And so they were kind of looking at the risks associated with importation, but also kind of thinking about, how effective were or would control and prevention measures be in that setting. And so they kind of observed a few interesting things. The median age of patients with COVID in Wenzhou is actually 45 years. It's actually on the younger side. 47% of those patients were female. The time onset between symptom and diagnosis was 0 to 23 days, with a median of 6 days. They modeled the spread of COVID-19 starting from January 21st. And they estimated that the demonstrated sort of intensity and starting time of control and prevention measures that were put in place did have major impacts on the subsequent spread of infection. And it was sort of interesting. I thought one of their conclusions is that if those measures had been delayed by only 5 days, the number of cumulative cases that would have occurred would have increased significantly and not actually have stopped until April of 2020. And the other kind of component to this is they actually include in sort of the modeling diagram, they include a compartment for asymptomatic individuals. We know now that there's some transmission happening from asymptomatic individuals. And so they actually note that it's not just isolating symptomatic patients or patients that have confirmed illness that have led to sort of improved control and prevention measures, but also that quarantining asymptomatic individuals was important using this data. Pretty interesting, I think. Sorry, go ahead.
No, please go.
No, just to say, I think these are some really interesting conclusions. I think very relevant as, states and cities in the U.S. start to think about control and prevention measures and kind of what is working and timing, et cetera. But also thinking about this component of asymptomatic individuals, I think was really interesting for me.
Yeah, absolutely. And Bijie Johns has joined us, and we're talking about COVID epidemiology in I'm going to say it wrong, Wenzhou, which I looked. It's on the coast of China. It looks like it's like 2/3 or 3/4 of the way to Shanghai from Hong Kong, a little north of Taiwan. I guess I don't know. I'm a typical American, so my geography is not great, but I found that I just did a Google map and it was helpful. Yeah, I mean I think that the asymptomatic or the asymptomatic / pre-symptomatic spread is important because one of the things that the figure part E curve was really interesting to me. It was it starts in January 21st when I started with the data. The protective measure started the 24th, and it really took about 2 weeks for there to be for them to get over that hump on the curve there. And I think, the 2-week incubation period seems pretty consistent across a lot of what we're seeing. So whether it's asymptomatic spread among people who got the virus from somebody and never manifested symptoms, or had it before they developed symptoms.
Yeah, the symptomatic point is very important. You're right.
Yeah, we just don't know, and it's so hard. And making decisions like trying to figure out if my family is going to come back and we're going to live together again and stuff like that. Part of it is a little bit of lag time after things look good to make sure both things aren't getting worse and I'm not getting sick, which is a little scary. Right. Yeah. All right. Anything else you wanted to add on this one?
No, I just, this is a modeling paper, I guess. And so certainly the assumptions that are put into, or the data that's put in are going to really sort of affect the results that come out. But I do still think that there's a lot to be learned from these types of papers.
Yep, absolutely. And I mean, even in the stuff where they're just presenting the data, there's no placebo group. There's no placebo Wenzhou that's really similar that didn't do this. And we saw what happened. It's really tough to make comparisons.
Definitely.
All right. So moving on to our last paper, we're going to keep the theme with azithromycin, but no more COVID. So this is azithromycin treatment versus placebo in children with respiratory syncytial virus induced respiratory failure, a phase 2 RCT by Kong and colleagues. So this is interesting. So RSV is viral. It's pretty common. We actually were seeing a fair amount of it this year before we started seeing all the COVID in adults, because it's on our respiratory panels, and it's been popping up a bunch. Most people tend to do pretty well with it, but it does cause, pretty substantial morbidity in kids is one of the reasons, one of the main reasons kids end up in respiratory failure in PICUs. And there's not a lot of directed therapies. In fact, most of the things that we try, things like albuterol and oxygen, we know don't work, and we still try them oftentimes because there's still a differential, even though we know it's not necessarily helpful. So this is a phase 2 trial where they're looking at azithromycin, with basically the idea being the anti-inflammatory hand wavy effects of it, which is interesting. And then I'm going to read, so their primary outcome was for looking for matrix metalloproteinase, or MMP levels. And I'm going to read from the study because I don't know a ton about MMPs off the top of my head, but MMPs are proteases implicated in the pathogenesis of both acute and chronic lung disease. In 2015, we, the study authors, reported that early elevation of endotracheal MMP9 levels was positively associated with RSV disease severity, and that MMP9 inhibition decreased RSV replication in a murine model, in a mouse model, suggesting that MMP9 might be a potential marker of disease severity and potentially a therapeutic target in RSV disease. So this is a phase 2 trial, which means it's relatively small. It's generally a proof of concept for efficacy and a dose finding study to some degree, which is still kind of typical phase 2. They only had 48 participants, which for phase 2 is, I think, relatively typical, a little on the small side. It's an average of 1 year old or 12 months old. And these were pretty sick. You needed to be on at least 5 liters of high flow nasal cannula to be in the study. And in fact, 70% were intubated and a quarter were on high flow, with the remaining 5% on BiPAP. 29 of the 48 kids had comorbidities as well, which is, I think, pretty typical for kids with respiratory failure from RSV. And then there were 3 different groups. There was a placebo group, there was a typical azithromycin group, and then a high dose azithromycin group. So it was 10 or 20 milligrams per kilogram. And basically what they found was that the safety was fine. There were basically no signals of harm in any of the safety here. There was no difference in the nasal MMP9 levels, which was the primary outcome. There were differences. There was an improvement in the endotracheal MMP9 levels, which is a signal towards potential benefit down the road. And there were also, if you look at all the different clinical markers, overall, there weren't a lot of differences. They checked a lot of different things, and it looked like overall the hospital length of stay was a little bit lower in the high dose group. And there were, overall, I think a slight trend or signal towards benefit in the high dose group, but nothing definitive by far, and nothing really meaningful as far as mortality, ventilation days, and things like that.
Yeah. No, I thought it was really interesting. It's always, it's like azithromycin coming back in all its different forms. So that's sort of interesting. I thought that me knowing nothing about MMP9, I thought that was sort of interesting, just looking at, the fact that those endotracheal levels rather were lower among those who received high dose samples. But what that means, clinically, I think, it's yet to be seen.
Yeah, I mean, this is a phase 2 trial. It's not. Right. This isn't definitive therapy trial. I am, on the very skeptical side of disease-oriented markers, like biomarkers like this. The fact that there was no safety problems, there were a couple of signals towards potential benefit, including, length of stay and these disease markers. That this, I think, helps set the stage for better trials. But I mean, I don't see a lot of kids, and I certainly don't see a lot of kids with respiratory failure from RSV, fortunately, because I work in a predominantly adult ED. But I think at this point, I don't think there'd be any reason to recommend it. It's just this is setting up, a safety profile for a phase 3 trial.
Yeah, definitely. we'll see what happens, I guess.
Yeah, absolutely. I mean, azithromycin's very hot right now.
Yes.
It's I don't know. I feel like we're gonna finish this pandemic either using azithromycin for everything all the time or never again.
Yeah.
Yeah. We got a couple more, Zed and Billet Decimi, who joined us. We are just finishing up talking about azithromycin for RSV. I think that's all we have for today. Of course, you can get these articles and more at jamanetworkopen.com. Everything's free and open access. We've got new papers coming out every weekday at 10 a.m. Central Time, and we'll be back next week, Tuesday, which is the 5th of May, 3 p.m. Central as well. So take care. Stay safe.
Bye.